Interplast Holland is one of the oldest organizations sending missions to especially Africa. We started it in '89, and we started this organization as a part of a very independent part of the big Interplast family. All the Interplast family doctors are white, but they share the dark heart that they have. I will give you a very short introduction to our organization. I will not overload you with data or other things, but I will tell you something about what we do, where we are present, who we work together, how our finances are, and what we think about the future. We started, as I said, in 1990, after we had a pilot's trip to Uganda. And then after the Gulf War, that was one of the reasons why we could not start in Ghana before. We had missions to Ghana and some other countries. We are a non-profit organization. We have no money. We only get money by donors, people who give 25 euros or less, and we have many collaborators who try to make our work possible. We have many volunteers, all people with this black heart, and we discuss here surgery, but we are a little bit different in the way that surgery for us is important, but training, and especially of the structures that support surgery, is even more important for us. We are a very small organization. We have an office with one person who organizes all the trips. We have a board of 3 persons, and we have lots of volunteers who make all the missions possible. Our main mission is reconstructive surgery, but also training on the spot of medical personnel, but also the people in the hospital and in the area around the theater. We do surgery on burns and congenital deformations, but also we try to achieve development in burn treatment. And we have a burn center in Uganda, in Kampala. It was in Mulago Hospital started, and recently it was moved to another new hospital where we have an 8-bed intensive care unit and 35 beds where we can treat patients with burn lesions of all the countries around the big lakes, Uganda, Kenya, and Tanzania. And there we have a team of 4 plastic surgeons who were trained by Interplast and were sent to all other training facilities here in Western Europe, and they make this treating of fresh and old burn problems possible. And we have a burn prevention program, and that is very important because we go with officers of this program to the rural areas, and we train the people how to prevent burns from cooking, lightning, and all kind of other things, and that reduces the amount of acute burns. The countries where we are active at this moment are on this screen, but there are many other countries where we no longer active because there is a well-organized system there, especially Ghana. We have a well-functioning plastic surgical department, and we were also many years active in Yemen, but unfortunately due to the war there, all our facilities, all our structure has been bombed by the Saudis, so nowadays there is nothing left at this area. We work together with the local staff. The local staff is leading for us. They tell us what they want, and we try to do that in a way. I am here as an anesthesiologist, and when you know history, you are familiar with the future. And we saw in the Western world that surgery development is always preceded by development of anesthesia. So learning the local doctors to do anesthesia, especially for major surgery and in pediatric patients, it's very important to have all new surgical procedures possible. So we do schisis, we treat acute and post-burn contractions, and we have this surgical burn center in Kampala. So we have very limited financial possibilities, but by the help of many people, it's possible for us to do more than 1,000 operations a year. So I have three theses for this meeting. The first is that in the beginning of our activities, we saw there was a lot of enthusiasm to work with us, and in the last 10 years that has become less. And one of the reasons for that is that the physicians and the medical officers are not paid enough to work with us together. Money is one problem. The other problem is to get education, is to have the time. And they should be set free for that. And the third reason, third question is that there is a tendency for African doctors not to be able to have training from our white specialists, but as you see in Kodeska, that you need a local organization to develop training on the job. And in the countries where we work, Kodeska is not available yet, so lots of people where we work are waiting for that, and they don't need us because we are probably doing procedures that are a little bit above that level, and the doctors who are there are not able to do this kind of surgery yet. Thank you very much.